everyone. I am Dr. Rahul Agarwal, Senior Consultant, Cardiac Critical Care Medicine Department at Care Banjara. Today with me is Dr. Narasa Raju, who is a Senior Consultant Cardiologist, Cath Lab Director, Care Banjara. Hello, sir.
Hello.
So today we continue with our earlier topic, heart attack, in which now we are continuing with heart failure. Can we know some things about heart failure, sir? In that, what is the difference between a heart attack and a heart failure?
Yeah, it's a very common doubt many people have. What is the difference between heart attack and heart failure? See, basically heart is a pump. It pumps blood through the body to meet the oxygen and metabolic requirements of the various tissues. So when heart as a pump fails to do this job, means when it fails to deliver blood to the various tissues, that's called heart failure. Whereas heart attack is a condition, it's an emergency where heart muscle is deprived of blood supply because of an obstruction in a blood vessel. Typically, it is because of an obstruction in a blood vessel. So this is heart attack where the heart muscle is dying, whereas heart failure is a condition where heart is failing to pump blood to the various tissues. Heart failure can be again like an emergency where we call it as an acute heart failure, acute decompensated heart failure, or it can be a chronic heart failure. Whereas heart attack is always an emergency where heart muscle is dying. That's the difference between a heart attack and a heart failure. Now, Rahul, what are the warning signs that patients should be aware of an impending heart failure?
Very commonly, sir, what the patients usually experience is shortness of breath. Whenever they are feeling air hunger or shortness of breath is one early warning sign of a heart failure. Second, they can feel there is a sudden rise in weight of the body. Or third, sometimes they can notice swelling in both the legs. Or sometimes they may feel a syncope or a giddiness or an arrhythmia. These are all the various signs where the patient should be very much early noting them down and coming to the medical emergency, which can be related to heart failure. So what are the major causes or the risk factors which can lead patients to heart failure?
So basically heart failure happens because of certain conditions called the risk factors or the major associated conditions. Typically it happens when the BP is not controlled, which is called hypertension. This can develop in diabetics, this can develop with obesity, this can develop with people who have coronary artery disease where the blood vessels of the heart muscle have blocks and hence the blood supply to the heart muscle is impeded or reduced, so that that leads to weakness of the heart muscle and leads to heart failure. So the common risk factors we have to say are hypertension, which is high blood pressure, diabetes, obesity, sedentary lifestyle, and stress, and heart disease in the form of blocks in the blood vessels of the heart. Dr. Rahul, as a critical care specialist, when does heart failure become an emergency from an ICU perspective?
From an ICU perspective, whenever patients are noting this shortness of breath, bipedal edema or a swelling in the legs or some kind of an syncope, they come to emergency. We try to see their oxygen saturation. If there is a drop in oxygen saturation or there is a drop in blood pressure or elevation in blood pressure leading to these symptoms, or they can find an abnormal changes in the ECG, which we do in emergency. These become a warning signs as well as indications for admitting to the ICU. So Dr. Narasa Raju sir, how important is identifying these heart failure patients to avoid them progressing to next level?
Yeah, it is very important to diagnose heart failure very early. The reason why is one, when we identify the heart failure early in the outpatient situation itself, outpatient setting itself, we can prevent an admission. So where heart failure is setting in or the heart failure is worsening, we can increase the doses or optimize the medicines and also correct certain factors like low hemoglobin or a thyroid problem, which can contribute to worsening of the heart failure. So we can identify these precipitating factors or the factors which are making the heart failure syndrome worsen and hence avoid an admission into an ICU. Moreover, when we identify the heart failure early on, we can address the basic factors which are responsible for the heart failure and we can treat them aggressively and prevent a progression of worsening of the weakness of the heart and hence a worsening of the outcomes in heart failure. In fact, we can prevent mortality. Nowadays, we have very good drugs. Once these drugs are initiated early on, the chances of the patient surviving in spite of heart failure is very high. Dr. Rahul, from your ICU perspective, when a patient comes with an acute heart failure, what are the initial steps and what are the further steps that you take to treat this patient?
Unfortunately, whenever these patients land up in an emergency or ICU in acute heart failure, sir, what we initially do is, as previously said, we check the oxygen saturation. If the patients are falling oxygen saturation, needing oxygen, we start supplementing with oxygen support. Meantime, we try to connect the patient's ECG to the monitor and monitor their ECG. And in case still if it is not settling down, we try to we escalate our respiratory devices, particularly non-invasive ventilation. If some patients needing, we go to invasive ventilation. Second, we check the blood pressure. If it is low, we take help of certain drugs called vasoactive drugs, which can be inotropes or vasopressors. These drugs will help us in improving their blood pressure, optimizing their hemodynamics. Then third, sometimes we have to take care of their arrhythmia part, where we involve our multidisciplinary team of cardiologists, EP specialists, and we try to address the problem as it is needed. Dr. Narasa Raju sir, what are the various investigations which help us in guiding the treatment as well as the progression?
So it's an important aspect. We normally, whenever we face this syndrome of heart failure, we do certain common tests, like some blood tests, which are basically looking at the markers of the degree of heart failure. Like there are now one important test called NT-proBNP, which is a blood test, which tells us about the significance or sometimes it helps in diagnosing heart failure. Sometimes it also helps in prognosticating the heart failure. Apart from such sophisticated tests, we also do markers of heart muscle injury called troponin, and of course we do tests like complete blood picture, thyroid profile, renal parameters, and liver function tests, which all guide us in the proper management that we have to give to the patient. So these are some of the blood tests. Apart from the blood tests, we also do tests like an ECG, chest X-ray, and an echocardiogram. Echocardiogram is nothing but an ultrasound of the heart muscle, heart's pumping function. So by calculating the ejection fraction, which is a measure of, it's a metric of the heart's pumping ability. So we categorize the heart failure syndromes into various categories, like heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, and based on the EF and based on the ejection fraction that we obtain by an echocardiogram, we monitor and also we direct the therapy accordingly according to the clinical situation. In selected cases where we suspect heart disease to be due to blockages, we do a coronary angiogram also, and tests like cardiac MRI would help us in diagnosing conditions like myocarditis, which can lead to heart failure. So these are some of the tests that we do which would guide us in diagnosing and also in managing heart failure in our practice. So Dr. Rahul, from the ICU perspective, what are the latest machines or whatever newer modalities which are available for an acute heart failure patient to improve the outcome?
So good that we have nowadays latest instruments as well as IT helping us with latest technologies, sir. In this, routinely first we try to take help of our ancillary gadgets like ventilators, needing of dialysis or needing of drugs. But despite that, if we don't get an expected response from the heart muscle, the latest modalities what we have is, first is mechanical circulatory supports like IABP, and then go to Impella, and then we have supports like ECMO, where we have problem more with oxygenation as well as circulatory support, where we need a respiratory rescue and circulatory support. We try to go for ECMO, or only purely we need more of cardiac support, we try to go for mechanical circulatory supports like Impella. These are the latest gadgets which are there with lot of advanced versions in them, which we take help of these gadgets. With the help of these instruments, therapies, we try to stabilize the patient and give some time for the heart muscle to recover in acute heart failure scenarios.
In your experience, these gadgets, did they make any difference to the outcome of the patient, and have you come across any real world scenarios where these ECMO and Impella, they made a difference to the patient?
There are certain, depends on the time of situation when the patient arrives to our facility or gets into our notice. Suppose the patients come early, yes sir, these definitely had made a difference. More of cardiac patients, devices like Impella, which are mechanical circulatory supports, they made a difference for bridging the patient and safely transporting to cath lab, where the procedure could have been done very easily without any complications in a high risk patients. And few cases which I have seen in this situation are for surgery also. We have sent patients on surgery and then push them to Impella post recovery. Recovery part of the heart failure with the LV dysfunction, these did a changes. We had outcomes and we have discharged the patients in stable conditions which are very high, where EF was 15-10% and all. Then definitely that made a difference. Even though our experience is limited, but yes, in this limited experience, it made a difference for the patients. ECMO, yes, right time initiation, but cardiac patients studies are unequivocal. But yes, they can make a difference for at least buying us some time for the patient, giving a respiratory rescue and circulatory support both. So these, yes sir, it all depends on the time patient presents to us and then how quick we are able to manage these conditions and then giving the outcomes depending on patients.
Yeah. So with the current generation of new medicines which improve the survival, improve the heart failure syndrome, addition of the newer drugs, the newer modalities have made heart failure survival a reality nowadays. So even with very sick acute heart failure, we are able to give a very positive outcome with the help of all the newer medicines as well as the various support systems that we have in our ICU these days.